So assessment and diagnosis is when we have patients who aren't responding to increased levels of oxygen. Um, we have whiteout in the lungs. We have high pulmonary pressures. We have pulmonary edema without the patient having a history of CHF. It can be something that's easy to miss unless you're looking for it. So any critically ill patient is probably at risk for ARDS. So we need to pay attention to what we're doing as far as invasive procedures, because it's easy for these patients who are debilitated, usually to begin with, to develop a sepsis. Medical management, some of the things that they use is PEEP. So PEEP may help open collapsed alveoli and increase the patient's ability to ventilate. Um, One of the problems with ARDS is that conventional ways to treat patients with low oxygenation levels don't seem to work as well. So they've done studies that show that ventilation with a large amount of tidal volumes and pressure actually causes hyaline membrane disease to be worse. So it's difficult to treat this disease once patients get it. These patients will absolutely be on a ventilator and in a unit. So all of the complications of ventilation is something that they are at risk for. Permissive hypercapnia, that's allowing the patient to have an elevated CO2 level in their blood. The reason why this works, or they think that this works, is it stems from the hypothesis that alveoli over distension at end expiratory collapse is worse than the respiratory acidosis that the patient may have. So they try a certain amount of different things with ARDS, and the jury's really out on the best way to treat this, because as you can see, with 50% of the patients not making it, we don't have a very good track record with this. You might see the patient do this. They have this inverse ratio of ventilation, so that what they'll do is they'll have some of the inspired air isn't allowed to exhale. And what that ends up doing is creating a positive end expiratory pressure, sort of like an automatic PEEP, okay, that the patient does themselves. And it allows for the lungs to be continually inflated. However, they're inflated with a gas that's not all oxygen. So what we're really looking for is adequate tissue perfusion, not just to the lungs, but also to the rest of the body, because anything that's reliant on oxygenated blood, and that's the whole body, is at risk because you can't get the oxygen to the patient's tissue. Nursing management is to optimize oxygenation and ventilation. One of the things you might see done with an ARDS patient is prone positioning. Now, nurses are very reluctant to put their patients on their stomach. We don't really like the fact that the patient's face is pushed into the pillow. It makes us very nervous, but prone positioning has been shown to work in some of these patients. These are some of the nursing diagnoses right here. Of course, impaired gas exchange, decreased cardiac output, imbalanced nutrition, etc. Things to think about for these patients: feeding, analgesia because they still may be in pain, sedation, preventing thrombophlebitis, head to bed elevation, ulcer prophylaxis, making sure that they have good glycemic control, because even though a patient is not diabetic, the higher their blood glucose level goes in response to stress, the worse they heal. They also will give these patients spontaneous breathing trials to get them off the vent as soon as possible. Sometimes with these patients, what we notice is that we tend to be so focused on the cause of the disease, or the ARDS, that we ignore things like the bowels, the patient's activity. So you see very little range of motion done for these patients. The fact that they need nighttime rest, not just rest during the day, but a rest that puts them on a sleep and wake cycle that mimics what the rest of us do. And then the other thing is to prevent any complications and to get them ready for discharge, preventing infection, making sure that they have adequate spiritual and skincare. Like I said, these patients are so sick, we tend to focus on the most severe parts of their disorder, and it can ignore things that are less critical. So pulmonary rehab, if this patient survives, this is where they're going to go. And it's a multidisciplinary comprehensive intervention for patients who have chronic respiratory disease. So remember, these patients are probably going to end up having chronic respiratory disease because of the ARDS. These are some of the disorders that are also seen in pulmonary rehab. It's not just for ARDS patients, but patients with COPD. Post-ventilated patients often go to pulmonary rehab, as well as patients who have had lung cancer surgery or who have had lung transplants or who are vent dependent. It's very difficult to find a permanent placement for patients with who are ventilated dependent. So we're going to do the case study that's actually gotten from a book that we used to have students buy, and that will walk you through a patient with ARDS. These are some of the respiratory, the pulmonary rehab components for patients. So home, the goal would be to get patients home if possible. So they'll do exercise and training and, see if they can control the environment to limit any kind of complications that might occur with the patient. And these would be the pulmonary rehab outcomes: reduced symptoms, increased exercise performance, the ability to perform ADLs, psychosocial symptoms are under control, reduced exacerbation of disorders or any kind of comorbidity, and then return to work or leisure activities. And this is it.